This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
That's everything from improving patient triage to just working with predictive analytics or AI algorithms to help get patients discharged or admitted into the inpatient setting sooner. We're seeing a number of organizations do some pretty interesting things there.
Welcome to SG2 Perspectives. I'm your host for today's episode, Jayme Zage. I am excited to have my colleague and co-host, Tori Richie, join me to talk about everything in the emergency department. Over the last 5 years, we've seen a lot of changes in how the emergency department is used and operates. I wanted to take a moment with Tori to talk about what clients are asking about, what we're seeing, and what we're predicting and forecasting with our upcoming forecast. Tori, thank you for being with me today.
Thanks for having me, Jayme.
Let's talk about the current trends in the ED. This could be a little bit of what we're seeing today, but also how it's different from what we saw during the pandemic and pre-pandemic.
ED visits are up in the historical data that we have access to, namely Vizient's clinical database. 2024 ED utilization was 4 or 5% above 2023. So we continue to see year-over-year growth in the emergency department. The latest volume projections also show ED utilization for the most recent calendar year was actually above pre-pandemic. It was above 2019. That's really interesting because I can recall a time where we saw so much activity in the emergency department leave that side of care, either because patients were deferring those services, they were being triaged to other ambulatory sites, and in the last couple of years seen a return of those volumes, which says to me there's probably still some opportunity for improvement in how we are triaging patients and how we're managing them upstream, because ED capacity and especially ED boarding continues to be a major issue in hospitals that then further creates these backlogs throughout the care continuum.
That reminds me of a current show. Actually, it just had its season finale, The Pit, if anybody's seen that. It's all about boarding in the ED, waiting for the beds upstairs, but also the volume of patients that are waiting in the ED waiting room just to be seen, and the triage process and all of those things. Are we still dealing with those kinds of issues today in the hospitals that you're talking with?
Absolutely. It's interesting. There's this duality of patients where you're blocking and tackling. You're managing the patients that are coming in with true emergencies. Think your myocardial infarctions, overdoses, what have you. Those are the individuals that move to the front of that triage line. They immediately get taken back into a bay. Then you have folks that do not have the requisite access to those ambulatory care services. And so for any number of reasons, either they don't have health insurance that allows them to receive proactive care. They aren't able to get an appointment in a timely manner, so that then pushes them to the ED. They just simply don't have the resources or the awareness to recognize that they should be going to an immediate or urgent care center instead of the ED. You have the folks where we need to be focusing on navigating those patients elsewhere to try to just reduce that sheer number of bodies that cram into the waiting room on a day-to-day basis. The Pit is the TV show that we're referencing, and just some of those scenes of people crammed in, shoulder to shoulder, standing room only, waiting to get released into an ED bay. The blocking and tackling we can't prevent, but then the prevention and the navigation is an area where we really have room to improve. And those are the types of conversations that I'm having with organizations.
And it's also the rising acuity that we've been talking about as well that comes in, and now you've got more patients who actually need to be admitted, but into an inpatient setting that's already at capacity. There's a dual bottleneck there.
There is. We need to be thinking differently about how we're building strategic priorities and service offerings for a cohort of our patient population. They have the health that they have. We're not able to reverse the progression of the conditions that they might have. We're not able to prevent the onset of the conditions that they already have. That is where we're not going to be able to turn the dial or turn the curve on that ED and inpatient utilization. Those are the folks that need to have that rapid access to those beds. For everybody else, we need to be investing in the care continuum, these support structures to work on those prevention and reduction and exacerbation of patients. Something else that we're seeing is if you look at ED volumes across different cohorts of hospitals, so thinking your academic medical center versus your community center, we see a divergence in utilization in those sites. That's interesting and is something that as a member of a community, we need to be better aligned with who's treating whom. For AMCs, we've continuously seen this increase in volume, and that's not necessarily the same trend that's being seen down the road at our community hospitals. That leaves a question to me of, first of all, there are staffing concerns. It's very difficult to staff a community or rural hospital. We've certainly seen an uptick in closures of facilities as well as beds in those rural and community hospital settings. But if we then are just simply pushing all of that volume to our academic medical centers, they're going to be slammed. It doesn't make sense for our low and medium acuity patients to go to that tertiary or quaternary facility. And that's where collaboration with other organizations and making sure that we're setting up meaningful partnerships so that all hospitals are working top of license, that they're upskilling, that they're tackling the highest acuity level that they reasonably can treat, which means decanting some of the patients that are going to those tertiary facilities today and making sure that our community hospitals are staffed and equipped to treat and manage those individuals.
That speaks to the importance of also working with your EMS system, whether they're private or they're a county provided. I know some hospitals have their own, but it's thinking about in your local community how EMS plays a role in that initial triage as well. Because if their instinct is always to go to the AMC, how do we redivert that? How do we have those conversations? How do we train the EMS to be able to say, this is a patient that could go to one of these community hospitals that may actually be closer in a lot of cases. Yeah, if the patient escalates or has a higher level of need, then you could take them to the AMC from there. But let's let them get stabilized, at least in those community hospitals.
Absolutely. If you just think from a proximity perspective as well as wait time perspective, if the tertiary facilities are slammed, the wait time there is going to be substantially longer than taking them to a closer or equally as far away community center where the wait time is much lower because everybody else is traveling down the road to that tertiary facility. Being able to think more strategically about how those volumes are being distributed and working with other providers within your market to ensure that we're optimizing how those patients are being distributed is key.
What are you seeing in terms of urgent visits? Because during the pandemic, we saw a lot of those urgent visits be redirected to other sites of care, not the ED. And in particular, when I was working on behavioral health, we started to see these behavioral health urgent centers that became the place that those non-emergent behavioral health patients started to go. Are we still seeing that trend, or has that also reverted back?
We've actually seen modest growth in those urgent, those low acuity ED visits. The growth is tempered in comparison to the emergent visits, those high acuity patients, but the use rate is continuing to climb. This says a couple of things to me. Number one, that between 2023 and 2024, we are still working through some of the direct and indirect delays in care that came out of COVID. In part, those delays happened because patients just put off healthcare services if they didn't need to receive them. In part, they also happened because it's been incredibly challenging to get into those ambulatory sites of care. What we've heard just anecdotally is that in some instances, providers are encouraging patients to present to the emergency department to receive diagnostic or imaging services, lab services that otherwise there are months-long waiting lists for if they were to use the appropriate channel. And that makes my heart drop to think about. Imagining an individual going to the ED to receive an MRI on their knee because they just simply cannot get into an imaging center in the next 6 to 9 months. And instead they're taking those ED resources. There's some element of mismanagement of who's going to the ED. Even beyond just that, if we think about lack of access that exists for chronic disease patients or aging patients, those with multiple comorbidities, as it's been challenging to access providers to manage those conditions upstream, we're seeing the exacerbation still of those conditions, and they're then presenting to the ED.
Or even just medication renewals and things like that.
A lot of different drivers for that continued trend. Keeping our eyes on the future, we're thinking not only about the proliferation of those trends, but also consumer-driven trends, increased in price sensitivity due to the economic standing, as well as then policy changes that might affect how and when and where patients are able to access care.
You've shifted us to the future. What are the trends that are going to shape the future? Is it the same stuff we've been talking about, or is there anything else?
One of our team members likes to say with emphasis this time. So it's a lot of the same trends, but we're drawing the double line underneath them. We, of course, can expect the population is continuing to age. The population is continuing to be more complex. Those things are not changing. And in fact, they're only worsening. Those trends are only being magnified. So that is an element that we're contending with. There are a number of question marks to us on the policy front, particularly related to Medicaid funding. And depending on what happens from a federal policy level, that could really change who has insurance, what the enrollment status is of a large swath of individuals who currently have more available access to those upstream services, to those disease management and prevention services. If things were to change meaningfully there, we can expect to see an influx of emergency department utilization when those diseases become exacerbated, when those conditions do progress. So that's something else that we're thinking about. Those are perhaps the headwinds that we're facing from an ED perspective. The tailwind side is that providers recognize these are major challenges that really face this side of care, and they're interested in figuring out, how do we start to turn the tide? We can expect to see some meaningful shifts in how we approach triage, how we approach scaling our workforce, how we approach some of that disease management and prevention, connecting with patients and educating them to ensure that they're being treated at the right time, at the right place. So those are perhaps the tailwinds that we're also expecting.
Can you give us any preview of what's happening in the 2025 forecast for the ED?
So we're quantifying those stories, and I cannot tell you a number, but from a directional perspective, we are expecting the emergency department forecast to be more aggressive, to be more positive this year than last year, particularly in the near term because of some of those near-term effects that we're quantifying.
Any idea when that inflection might be where we're not doing 4 to 5% growth every year?
We're at that point, frankly, in the time since 2020. We saw the valley of volumes in 2020 and 2021. In the back half of 2021, we started to see an increase in volumes. That continued through 2022, but 2022 is when we hit the peak of our workforce challenges and our peak workforce burnout, which then created these backlogs in the ambulatory ED post-acute sites that pushed patients to have to delay care. We started working through that backlog in 2023, and we feel like we've really continued to work through that backlog in 2024. There might be some element of still working through those patients in 2025. But if we look at some of the recent volume trends, we feel like we are back to normal for the most part. I mean, we're at or past pre-pandemic utilization. There's only so much more that we can push the sheer number of volumes that we're treating if for no other reason the physical constraints that exist. 4 to 5% is unsustainable from this point forward.
You mentioned some of the tailwinds that are maybe going to help us turn that tide. What are some of the solutions that you're seeing that could help us better triage patients, better move them through the system, create access in different ways? Or are there even alternatives that we're seeing come up for some patient populations?
Investment in ambulatory infrastructure is a big one. That's virtual health, that's immediate care, that's urgent care, that's chronic disease management programs, what have you. Investment in these areas helps divert low acuity patients from the ED. It's going to require scaling access, and not just physical access, but even access to same-day appointments, making sure that we offer hours that extend beyond just the standard 9 to 5, making making sure that we're scaling our care continuum to meet those needs. That's going to take time. Definitely. It takes time and it takes quite a bit of resource capital to be able to execute on that initiative. Improved throughput is another big one. So that's everything from improving patient triage to just working with predictive analytics or AI algorithms to help get patients discharged or admitted into the inpatient setting sooner. We're seeing a number of organizations do some pretty interesting things there. We've seen everything from split flow models where an organization triages a patient as soon as they walk in the door, a nurse and APP or physician partnership. They flag a patient either as high acuity or low acuity. If they are low acuity, then the question becomes, do they really need to be treated in the ED or can we just send them to an urgent care center down the road? If they're high acuity, where do they fall in the high acuity triage process? This means that they're even thinking through what labs should we order? Are there orders that we should put in now so that when they do get in a bed, we already have all of that paperwork done and we're able to process them faster? That's been incredibly helpful. Fast track systems have also been put in place in a number of organizations. In some hospitals, patients are able to join the queue before they physically get to the ED, which is great as well, a virtual waiting line, so to speak. One organization also partnered with Toyota to develop a stoplight system where outside of all of their ED rooms, they have stoplights basically. And depending on the light that is illuminated outside of the room, that indicates to the staff what the next step is for the patient. If it's green, that might mean that the patient is ready for discharge. If it's red, that might mean that the patient is waiting to be taken down to imaging or what have you. And just having those visual cues has allowed the ED to work much more efficiently without having to tap into the patient chart. So just thinking through even creative solutions like that for how you're optimizing workflows.
You mentioned having patients put themselves on the waiting list. I've seen some EDs where if you look online, an organization that has multiple EDs will share the wait times of the EDs so that if you're going to be a walk-in, you are probably going to choose within a distance parameter that with the lowest wait time. So that's another way that I've seen some organizations start to help balance the load.
To that end, I was on the phone with an organization a couple weeks ago and they asked, do those wait time billboards work? And I said, yes, they work. I mean, especially if you're able to guarantee a wait time of 30 minutes or less within your ED, and a patient is just used to driving by that billboard every time that they go to the grocery store or every time they go to the office. The marketing power that exists with something as simple as that is highly effective, and you're optimizing your workflows to be able to meet or beat those wait times. That's a huge satisfier that then gains you satisfaction points with your patient population.
That's another big part of the PIT. And they talk about the Press-Ganey scores and the patient satisfaction scores and how in this particular show, the CD gets terrible satisfaction scores. And not to be a spoiler, so I won't give out the details, but it does manifest for one patient that has a very long wait and is very dissatisfied with it. Managing those expectations even. So even if you tell patients up front, it's going to be a 2-hour wait, or you can go down the street to this other location, that can help manage those expectations as well.
Definitely. And something that we've seen be successful, we have a member who deployed a model where if a patient is in the emergency department waiting room, at least once an hour, a staff member is interfacing with every patient. So it might be something as simple as, hi, Jayme, I'm so sorry that you've been waiting for 2 hours. Here's where you stand on the list. Is there anything that I can get you? Let me point you to where the break room is, to where the lunch room is. It might not be a promise of we're going to get you a bed at X time, but just making that human connection while patients are in the waiting room has gone a long way to improving patient satisfaction. Just adding that human element of care and going out of your way to connect and make sure people know they haven't been forgotten about. So easy to execute on and hugely effective.
Yeah, some lessons from the restaurant industry with online queues and the ability to walk around. One of the biggest fears waiting in the ED is that if you get up even to go to the bathroom, they might call your name and then they'll skip over you if you don't come. So how do you start to think about the patient experience and all that and allow them to move around, get out of that crowded ED, go out into the outside and get some fresh air if that is what they need, or like you said, go to the cafeteria and just get a little bite to eat if they're going to be waiting a while.
Set up that text notification system. You're next in line, report back to the emergency department in the next 10 minutes. That's a simple enough algorithm to set up and go such a long way.
Absolutely. What is a word of advice that you might offer to our health system clients about how to prepare for the future in the ED?
Recognize that the patient demand is there. The patient demand is only going to grow for these highly complex true emergencies, and make sure that you have a proactive plan on how you're going to manage this patient population. In a lot of instances, there really is no reason why we have to get to the point where an emergency department visit is necessary. For those instances, be investing in and be building out that ambulatory infrastructure so that we're able to prevent that encounter from the jump. And in those instances where we're not able to prevent those stays, make sure that you're optimizing those care pathways so that you're operating as efficiently as you possibly can.
That's a great way to end our episode today. Thank you, Tori, for joining me on a very fun conversation about a challenging topic. And thank you to our listeners for listening today on SG2 Perspectives.
If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.